All right, everyone. I think we're going to go ahead and get started and do just a few minutes of welcome. So hopefully anybody who's still planning to join us will do so before we get into the meat of today. But we really are so excited for this town hall, and we have a lot to go over with you, which is why we don't want to wait any longer to get started. So I'll just start by introducing myself. I'm Shelly Facente from Facente Consulting, and I'm so excited to be here today with the team from Facente Consulting, who has been working closely with CDPH, and you'll meet three more of us today as we present information. And I'll introduce some CDPH folks momentarily and pass it off to them for a welcome. I did just want, for housekeeping, to just let you all know you got the reminder when you checked in that this is being recorded and will be available afterwards. And we will send out information to anyone who is on the registration list, which should be all or at least most of you. If for some reason you're not on the registration list and you think we don't have your email, go ahead and put it in the chat. You can chat privately if you don't want to send it to everyone, and then we'll make sure that any of those names that were put in the chat will get on the list. So let me just quickly give you an overview before I hand it off to our colleagues at CDPH for a welcome. We're in the welcome and introduction phase. Then we'll have a big chunk of time today where the Facente Consulting team will provide an overview of the strategic plan, which hopefully many of you have already had the opportunity to look through and become familiar with, but we'll give you a little more background of how we got here and where we're going after this in 2022. And then we have some of our colleagues at CDPH will share just a bit of some of the innovation and advances that are already happening as part of rolling out the strategic plan. Then we have three guest speakers who are here to talk about structural changes statewide, which we know will be really interesting to you all. And then we'll officially close, but we should have about 15 minutes left where we want to make sure we have opportunity for you to give us information and feedback and ideas that you have. And we'll have three ways to do that as part of today's event before we close. So if there's nothing you want to share, you just came for the information, we'll probably end a little bit before 2, but if we really invite you to participate in this community engagement piece and share some information. And as you'll hear today, this is just a taste. This is just an opportunity because it seemed like it would be a shame to miss having all of you here and not be asking you for your input, but this is certainly only the first of many opportunities to give much more detailed feedback. So don't feel like this is your chance and we're only giving you 15 minutes because it's way more important than that. So with that, I'll just share, these are, there have been many people, as we'll talk about today, who have gone into this process and helped make this what it is to date. But these are some of the folks who are really leading the charge today and who you'll hear from throughout the town hall. And so we wanted to kind of start with that. And I will pause and hand us over to, I think we're going to have Marissa Ramos. Are you going to?
I'm here.
That's great. All right.
Yes. Okay. Welcome, everyone. I'm so excited to have everyone. It seems like we have a full house, so this is exciting. I am one of the many people that are very, very, very proud of this plan. It's one of the first ones of its kind in CDPH, so I'm excited. We've tried something new, and I'm excited to get to phase 2. We're acknowledging this endemic, and we're addressing not only HIV in this new plan, but integrated with HCV and STI. We're committed to this new vision, this new vision, mission, and our core values of the plan. And one exciting thing as well is Dr. Tomas Aragon has really appreciated what we've done with this plan, and he's excited and willing to assist us in any way to move this forward and within the next 5 years. So welcome, and I can't wait to hear everyone's input on the plan and during this phase 2 of it. So thank you for being here. And I'm going to hand it off to Kathy. Are you out there?
What is going on? Hello. Hey, are you guys calling me?
Yes, go ahead, Kathy.
You know what? I just had a computer blackout. I don't know if that happened to everybody, but everything just went black on me. So, and I had to restart everything. So my apologies. But just to say to everybody, really excited to have you here. You know, we're really excited about this strategic plan. Because it's really taking a comprehensive view to the syndemic as opposed to an epidemic. And also, you know, really looking at it from what's driving these epidemics, which are the social determinants of health. I just want to talk to you about a couple of initiatives that the SE Control Branch is working on in collaboration with Office of AIDS. But just two areas that I see align well with the strategic plan. One is that, you know, and most of you that know me know that I'm passionate about testing in emergency departments. And that's really due to the fact that, you know, social determinants of health mean that some of our patients just are not in a position to utilize the healthcare system that we've put out there. It just doesn't fit their needs. You know, we're expecting people to show up from 9 to 5, often waiting long times in lines, waiting to get an appointment for 2 months. And, you know, if we really want to impact the populations that are most impacted by STDs, HIV, and Hep C, we really need to learn to work closely with them and meet them where they're at. And that's why I'm so passionate about testing in emergency departments, because that is the one and only time that these individuals often access care, emergency departments or correctional facilities. And we really need to capture that moment and take advantage of that opportunity to, you know, both identify individuals, but also not just identify them, but treat them and utilize that one and only moment that we might have that they're passing through our fingertips to test them, treat them, but also address their social determinants of health that are making it more challenging for them to utilize the systems that we've put into place. But I really believe our systems have to change if we're going to make a difference. Another initiative that we're looking at is that, you know, we've spent the last 2 years developing an in-depth infrastructure for COVID with a focus really on social determinants of health and accessing those populations most impacted by COVID. Well, those populations are the very same populations that are impacted by STD, HIV, and Hep C. And so we're really looking to utilize that infrastructure that's been developed to better access our patients. And I think this strategic plan aligns very closely with those two initiatives, or vice versa, I should say. Those initiatives align closely with the strategic plan. And we're really looking forward to hearing from all of you other ways that we integrate ideas that you all have into this strategic plan to make it effective. And with that, thank you all for coming and look forward to hearing back from all of you.
Thank you so much, Kathy. All right, so now I'm going to share the screen again and dive into the section where we overview the strategic plan. So to start, you know, we really want to acknowledge that as a state and each individual county in California, there have been thousands of people doing incredible work towards ending the HIV, hepatitis C, and STI epidemics in California. From the implementation of PrEP and PEP to U equals U, to meaningfully integrating the expertise of people with lived experience in these diseases to ensure programs are the best they can be. All the things on this list you see before you on the screen. The work that we've been doing in California has been vital and continues to be a model for this type of work across the nation. However, there is still much work to do, as not everyone has the same access to or benefit from these important interventions, which is really what's underlying this plan. Oh. Okay, so to put it bluntly, despite these amazing strides we've made in California, it's clear that the benefits of these advances have not been experienced equitably. In fact, HIV, Hep C, and STIs are interrelated, and all three of them impact many of California's least privileged communities much more than in other populations. So just a few examples of this are on your screen. And just to call a few of them out, people who are Black or African American, white, and American Indian or Alaska Native experience a much greater burden of hepatitis C infection than should be true given their population size in the state, which is what you see in this graph on the left. On the right, you can see there are gender-based disparities in STI diagnoses. And for syphilis, gonorrhea, and chlamydia, people who are Black or African American have more cases per 100,000 Californians than any other racial group. Another example, not on the screen, the rates of early syphilis increased 450% among women of childbearing age in California from 2012 to 2016, which has resulted in the number of infants born with congenital syphilis in California increasing for 5 consecutive years. There are even more statistics in the full strategic plan document highlighting further inequities. And it's clear that to make sure all Californians have an equal chance to experience health and wellness, we need to enhance our current work to address HIV, Hep C, and STIs to pay particular attention to those who aren't yet thriving. So with that in mind, what did we do to get here? The CDPH Office of AIDS and STD Control Branch, and you just heard from those chiefs, joined together in early 2021 and set out to develop a high-level, high-impact strategic plan for addressing HIV, Hep C, and STIs over the next 5 years in collaboration with Facente Consulting. So to do this, we convened a work group of 25 people from CDPH, statewide organizations, and other stakeholder groups. And those dedicated people met for 90 minutes every Tuesday for 13 straight weeks, which is a lot. So this is the work group. And I won't take too much time here except to acknowledge everyone on this list and extend my gratitude for all their commitment and hard work over the last year, because it was a heavy lift. It was a lot. And their names are also on the last page of the plan if you want to take a closer look today. So I'll move on for now. So what did this group decide? Well, we knew that we wanted to treat HIV, hepatitis C, and STIs as a syndemic. So that word is kind of a classic example of public health jargon, but in a syndemic, it means that having one issue places a person at greater risk for another one in the syndemic, and having 2 or more health issues at the same time makes one or both health issues worse. So for example, having syphilis or gonorrhea can make it easier to get HIV. Having HIV can make it easier to get Hep C through unprotected sex. And having HIV and Hep C at the same time can make liver disease get worse faster than having hepatitis C alone. So we know that's true for these conditions. And we know that it means that each of these things impact some of the same people disproportionately. So what does it mean to say that we wanted to treat this as a syndemic? That's easy to say, but what does it mean? Well, we didn't want to have a strategic plan that had an HIV chapter and a hepatitis C chapter and an STI chapter, as if those things were not really related. And we didn't want to recreate silos of prevention, care, testing, or data. We know those are the cornerstones of our work on these issues, but we also know that integration and thinking of these things as part of a whole picture is really critical. And so we didn't want to segment it in that way. So ultimately, the group decided that to best enhance our work by focusing on those Californians who still haven't had the opportunity to thrive in these areas, we needed to look at the issues through the lens of social determinants of health. And you'll hear more about that and exactly what that included from my colleagues in a moment. So to help make this happen, we invited more than 24 speakers to these meetings over those 13 weeks from places like the Injury Prevention Unit which focuses on overdose within CDPH, the Department of Corrections and Rehabilitation, the Department of Education, Children and Family Services, and the California Pan-Ethnic Health Network, and many others that I didn't list here, to talk to us about the relevant work they were already doing, where there were synergies, and then to collaborate with us to develop the strategies that you see in the final plan. So a lot more people than just the 25 that you saw on that list really were involved directly in helping to bring this about. We also released an open survey that was taken by more than 640 people throughout California in both English and Spanish. And that was to gather ideas and insights from the greatest range of people possible before we settled on some strategies. And then we had multiple rounds of revisions to land on a plan we felt could be actionable and visionary, which was the version released last month, which hopefully you've already seen, but we'll give you more details today. And this is just the beginning, as you'll see from the town hall today. So in summary, this brings us to the strategic plan. So this strategic plan, we're really excited about it because it acknowledges root causes of HIV, Hep C, and the STI syndemic and works to address them. It approaches the work from a social determinants of health lens, which really, we talk about social determinants of health a lot, but actually framing this plan from that lens was challenging to do well. And we really feel like it's something that's going to move our work forward substantially. It also supports reframing the work already being done to transform the systems and meet the needs of people most neglected to date. And it also highlights and enhances existing public health efforts and activities that have contributed to successful outcomes. We certainly didn't want to act like it's all has to be new things because what we're doing isn't working. We know what we're doing is working. We just need to add some extra oomph to really make sure that we're meeting the needs of everyone. So as my last slide before I hand it off for more details on the strategies, just so that we're all on the same page, our vision that we discussed when we put this plan together was that we envision a California free of systemic racism and new HIV, Hep C, and STIs, where, and this is written out, so like new HIV, Hep C, and sexually transmitted infections, where all people with these conditions easily obtain the services and resources needed to live healthy, dignity-filled lives free of stigma. This is the California that we're envisioning and that we're trying to achieve, we're trying to get ourselves closer to through the work of this plan. Our mission is to center equity and racial justice in our work and eliminate health inequities among those most affected by HIV, Hep C, and STIs in California. And the purpose of this plan itself is to define the key strategies that California wants to undertake to end this syndemic in California using a social determinants of health framework. And you can see the core values in the plan that are listed on this slide. And there's more detail about what we mean by each of these things in the plan itself. So the 30 strategies contained in this plan, which we'll go through in a moment, are still high level. They're meant to guide the priorities, resources, and overall focus of our work together to address HIV, Hep C, and STIs throughout California in the next 5 years. But the next step is to work at the local level to figure out how to turn these 30 strategies we'll go through today into things that aren't theoretically actionable, but can and will be implemented in ways that have real impact. So you'll hear more about that process from Katie in about 10 minutes, what that process will be to work with you. But first, my colleagues Lasada and Sada are going to provide an overview of the 30 strategies in the plan. So I'll hand it off to Lasada now.
Thank you so much, Shelley. So our first social determinant of health is racial equity, as you will see here. Profound racial and ethnic disparities in health and the overall well-being of Black, Indigenous, and other people of color, BIPOC by its initials, have long been a public health issue, so much that it was declared a public health crisis by CDC in 2021. The data show that racial and ethnic minority groups throughout the US and in California experience higher rates of illness and death across a wide range of health conditions when compared to the white counterparts. It's what we saw in our slides previously. Additionally, the life expectancy of non-Hispanic Black Americans is 4 years lower than that of white Americans, reaching the most vulnerable populations and communities necessitates us to focus on strategies that are intentionally addressing systemic challenges that impede marginalized communities of color from accessing services. And so, to advance progress towards reaching racial equity, CDPH is prioritizing these 5 broad strategies that you see here over the next 5 years, including leadership and workforce development, which means increasing the proportion of BIPOC public health staff, leaders, and allowing the growth to happen within. Racial and ethnic data and stratification that reflect the specific trends, needs, and outcomes of communities of color. Equitable distribution of funding and resources, using a racial justice lens to advance equitable delivery of resources. Community engagement to reframe the infrastructure of services and the messaging that we put out. And racial and social justice training to strengthen our movement towards achieving cultural humility, equity, and racial justice. Our next and second social determinant of health is housing security, using a housing first model. There is no standard definition for housing insecurity. However, research maintains that housing that is stable, safe, clean, and adequately maintained can reduce the likelihood of adverse health outcomes. Californians experience houselessness at higher rates than most other states throughout the US. Housing costs, limited rental market with few affordable vacancies, and discriminating policies on who can access housing are a very select few of the challenges that people may experience. California law defines housing first as an evidence-based model that centers on providing or connecting people experiencing houselessness or homelessness to permanent housing as quickly as possible. Additionally, through the WIC Section 8256, state programs are required to adopt guidelines and regulations to incorporate core competence or components of housing first into their programs. So what does that look like for us in the next 5 years? Specific to HIV, HCV, and STIs, we propose data collection and use that is better monitored, allowing for depiction of differences in HIV, HCV, and STI rates, and health outcomes by housing status. We propose infrastructure changes, multidisciplinary teams to address the syndemic, including increased support services, new models of housing access, explore development of a permanent housing model with priority populations, street medicine strategies, meeting people where they're at to provide basic medical care and support services, and low barrier housing options, ensuring broader availability throughout the state. Our third social determinant of health is access to healthcare and services for all. Although California has led the nation in expanding access to health coverage through programs such as Medi-Cal, which we'll hear about today, and CalAIM, many people still struggle to afford medical care. Californians have reported having to use life savings, forging their paid time off and vacation time, or having to borrow money to pay for their medical care. Added challenges have included finding primary care physicians or specialty providers that accept new patients, have available hours, and/or are local to where people live. Ending the HIV, HCV, and STI syndemic will require increasing access to quality healthcare and removing those barriers. We propose this through redesigned care delivery with increased access to telemedicine, mobile healthcare, and at-home testing programs. We want to offer trauma-informed and responsive services through trainings for medical and public health service providers and ensuring that the appropriate response efforts are in place. Fewer hurdles to healthcare coverage through support with benefit enrollment. Culturally and linguistically relevant services improve the capacity to respond to culturally diverse groups. And through collaboration and streamlining, which allows ample sharing of info and resources. And now I pass it over to my colleague, Sara.
Thank you, Lazara. So the fourth social determinant of health that is focused upon in the plan is mental health and substance use. We know that mental health and substance use are interrelated and that they are factors in a person's risk, ability to protect against HIV, HCV, or STIs, and also a factor in engagement and care. The 5 strategies proposed under mental health and substance use are: number 1, overdose prevention in correctional settings. Studies have found that incarceration shortens lifespans and inflicts long-term damage on people's mental health. Incarceration also greatly increases the risk of fatal overdose. So this strategy promotes medication for opioid use disorder during incarceration and continuity of care as a person transitions back into the community. 2, mental health and substance use disorder treatment access through telehealth, effectively increasing access to resources across the state. 3, build harm reduction infrastructure. We know that syringe service programs save lives, support people into treatment, and provide prevention interventions to those at high risk. And this strategy helps to support those that are already doing this work and also to provide additional resources to expand these vital services. 4, expand low threshold substance use disorder treatment. And 5, cross-sector collaboration between traditionally siloed sectors of public health and between local and statewide programs. Economic justice. The strategic plan recognizes that California has one of the top 10 income gaps between the rich and poor of any state. We see disparities in wage gaps, gaps in employment due to incarceration, disparities in education and job opportunities, and continued discrimination in the labor market. These inequalities have direct implications on people's risk and their ability to engage in proper care and treatment. The strategies in the plan are: first, workforce development to create pathways to employment and public health for people from impacted communities. Number 2, employment for people with lived experience. This includes reviewing employment practices, living wages, and/or leadership representation when deploying grant funding. 3, equitable hiring practices and fair pay, examining hiring practices at the state and local levels to ensure barriers to employment are resolved. 4, funding and supporting leadership development training programs for those that are doing the work in the HIV, HCV, and STI fields. And 5, working with partners to move toward universal hiring and housing policies that would eliminate barriers to opportunities. For example, by removing questions about criminal history from application processes until after demonstrating qualifications. And last, but certainly not least, the 6th social determinant of health in the strategic plan is stigma-free. The extent to which people will reach out for care or support around a disease they think they may have or know that they have is directly related to their past experiences with discrimination and stigma, including racism, homophobia, transphobia, among many others. The 5 strategies for counteracting stigma are: 1, nothing about us without us, meaningfully and consistently involving the voices of people living with HIV, HCV, and STIs in planning, decision-making, service delivery, and evaluation. 2, reframe policies and messaging to ensure people or behaviors are not stigmatized. 3, positive, accurate information, ensuring that the language and images that are used in communications show accurate and diverse depictions of communities and that they don't reinforce stereotypes. 4, acknowledge medical mistrust. Medical mistrust is a rational response to stigmatizing and discriminatory treatment. Then, with that acknowledgement, work to build trust with communities. And 5, ongoing partnerships with people from the communities being served to educate, support, advocate, and link to care people who have historically been mistreated by public health services and the healthcare system. Now that we've discussed the 6 social determinants of health of focus in the strategic plan, I'm going to hand it over to my colleague, Katie Burke, who will discuss next steps.
Thank you, Sarah. Hi, everyone. Happy Friday. Excited to be here. So I'm going to talk a little bit more about what comes next. But first, just want to share this slide to really review our commitment. And so what I'm going to talk about is our process for collaborative community engagement processes, because we want to make sure that we're hearing from all of you, and that we can really kind of align these strategies and make sure that they're making sense on the local level for all of you. And I know CDPH is invested in sharing data and information as appropriate. So we're going to talk about our efforts to keep the communication going throughout the development of the plan. Next slide, please. So what comes next? So, you know, we're harm reductionists, so we want to offer a variety of options for you all to participate and kind of multiple thresholds. And so obviously you're here at the virtual statewide town hall. We wanted to start with this to get everyone on the same page about what the plan was. And then we can start to talk to you all about what implementation can and should look like in your local jurisdiction. In the next month or two, there will be a survey that goes out with some more follow-up information and kind of assessment for you all. So please look out for an announcement about that. And then in May and June, Facente Consulting is going to hit the road, and we're hopefully going to come to a town or city near you. We'll have a series of meetings and focus groups to really talk to folks again about implementation strategies and working on developing the blueprint to guide all these activities at the state, regional, and local levels. And then we'll put all that together. There will be a final review and dissemination period, and then the submission to HRSA and the CDC. Next slide. So again, today's really about getting everyone on the same page with the CDPH strategic plan. And we want to be clear that sort of the overall policies and priorities and frameworks are decided, but the community engagement process will really drive the implementation plan. So any feedback steps like the survey coming up will help the meetings, you know, that's all of course voluntary, but we do think it's beneficial for you and your communities to really think and talk about how this applies to you. And what makes sense in terms of the implementation in your region. Next slide. And then we have a couple asks of you all too, right? So what does this mean for you all as local health departments and community-based organizations? I think first of all, we really recognize this is a paradigm shift. This is a different way of approaching our work around HIV and Hep C and STIs. And it is okay if that feels uncomfortable or unfamiliar in any way. What we would hope is that you all will kind of lean into the process by thinking about, you know, what this means and what it would look like in your communities, and really start to talk to your colleagues about local strategies. And then we just want you to participate. So, you know, maybe some of you are going to get what you need from the town hall today and feel done after that, but we hope that more of you will really continue to engage in the other steps in the process, and also help us make sure we're being as inclusive as possible. So you can do that by considering all the intersectionalities in this work, and help ensure involvement of relevant local groups. And that might mean folks who haven't necessarily led in terms of HIV or SC or STIs historically, but they may, for example, lead anti-racism initiatives. So we need that expertise at the table. We need everyone's expertise for this planning process. Next slide, please. And so just a little bit more information about the road show that's coming up in May and June. So we are currently in the process of scheduling in-person community engagement sessions according to the above schedule. And again, the idea is to get as much feedback from you guys as possible. All these dates are tentative and can change, but if you look through this, you'll get an idea of kind of the different regions we'll be in different weeks, and the specific cities that we're hoping to host sessions in. And so we'll probably be reaching out to a lot of you to help us get stuff on the calendar, help us identify, you know, locations where we can have these meetings, and to help us get the word out to all of the partners in your jurisdiction. So we're really looking forward to this work, and we can't wait to hear from you all and hopefully meet you in person soon. That's it from me. I'll go back to Shelley. Thank you.
Great. Thanks so much, everyone. I'll stop sharing for just a moment and just say, we know this was a lot of information. There's even more information in the plan. And ideally, we would have a whole bunch of time for Q&A from all of you, because I'm sure at this point you have a lot of questions. And there are more than 300 people on this call. And so it's not really practical to do an open Q&A, but we would like to invite you, if you have questions, to put them in the chat, either to everyone or directly to one of the presenters if you'd like. And we will do our best to get back to you during this if we can, and certainly we can also follow up with a more comprehensive email response later if needed. So then with that, we would like to move on by introducing Dr. Marissa Ramos to share a little bit about some of the innovations and advances already happening at the Office of AIDS at CDPH.
Let me get out of mute. There we go. Thank you, Shelley. So I'll share a couple initiatives that we have going here at the Office of AIDS, for example. Just a couple examples just because of time's sake. So, we have made significant progress to improve HIV health outcomes here in California. However, more effectively addressing this endemic and its underlying social determinants requires that we do things differently. We are already doing some of this work, and I'm going to give you just 2 examples of that work that we're doing here at the Office of AIDS. The first one is our street medicine, which is a model developed by the Keck School of Medicine that effectively delivers mobile primary care and other supportive services to in-house communities throughout California. We're adopting this proven model into our Ending the HIV Epidemic efforts. The second one is the Take Me Home, which is an intervention developed by Springport Health that offers home-delivered HIV, STI, and HCV tests, effectively putting integrated screening tools directly into the hands of clients in 6 counties now. And we will be scaling this program up to serve all the counties in the state of California. We will be looking to support and expand projects just like these 2, and learning more about how to apply a status-neutral framework so that HIV, STI, HCV prevention, and care become a seamless family of services to clients that need them most. We will be looking to hear from all of you. We want your ideas over the next year so that we could integrate it into our plan. So again, please participate in these community meetings that will be held throughout California. Thank you. And I'm going to give it over to our partners over at the STD Control Branch, Rachel, Jessica.
Hi there. Good afternoon, everyone. My name is Jessica Fraser-Williams. I'll get us started. I'm the Program Development Section Chief at the STD Control Branch. And the STD Control Branch has had a very long-standing relationship with the Office of AIDS, and we collaborate across many aspects of our work that overlap. And I'm going to highlight one focused on STDs, and then my colleague Rachel McLean is going to highlight one focused on hepatitis C. So as Shelley mentioned at the top of the call, we've seen alarming increases in congenital syphilis in recent years. And we've also started to see some concerning increases in perinatal HIV transmission in the same populations. All of these populations are impacted significantly by social determinants of health as outlined earlier in the integrated plan. So some examples of where we're already working together to address these endemics include a Dear Colleague letter we co-published at the end of last year, focused on providers, alerting them to these issues and encouraging them to expand syphilis and HIV testing, treatment, and PrEP in pregnancy specifically. And then also, we are working on a pilot project in San Joaquin County right now that provides open access prenatal care and wraparound services to people experiencing homelessness and are using drugs. And that was built and modeled after the Team Lily program in San Francisco. We're just starting this work, and we'll need input from all of you as we go through this next year of development of the blueprint to help us think further outside the box as we continue to move forward. So thank you all for joining today. And I will pass the mic to Rachel McLean.
Hi, thank you, Jessica. So I would just add to what Jessica shared that one of the other things that we just started in the last 6 months that we're really excited about is sharing a line list of people. Basically, the Office of AIDS sends a list to local health jurisdictions of people who they think are out of HIV care so that can help them get back into HIV care and treatment. And I know when I started in this position in 2008, I thought, wow, there's all these resources for HIV. I wonder what we could do to support people with HIV Hep C co-infection, because we know that if someone has both HIV and Hep C, the chances of them getting liver disease happen like 10 years faster than they do with someone who only has Hep C. So, you know, it only took about 14 years, but we now have incorporated Hep C care status information into the HIV list that is sent out to local health departments. So now local health departments can identify people with HIV Hep C co-infection who we think are out of care and really try to help get them treated for hepatitis C and cured. And it would really be wonderful if we could reduce the number of people who have HIV Hep C co-infection now that Hep C can be cured in 8 to 12 weeks with all oral medications with limited side effects. It's really an exciting time. And the other thing that we're doing, I really would say across the STD Control Branch and Office of AIDS, is thinking very deeply about racial equity and how we can really center racial equity in all of our work, both internally and externally. How can we center racial equity in our contracts, in our funding, in our hiring, everything. So we would really love your feedback about how to do that. And we're really looking forward to seeing what comes out of these town hall events that Shelley's group is doing. And we really look forward to hearing more from you. So thank you.
Great. Thank you so much, everyone. Now I will hand it over to Lasara, who will introduce our guest speakers.
Thank you, Shelley. And we are excited to invite 3 spectacular guest speakers today with us. And they will be sharing information from the California Department of Public Health's Office of Health Equity, California Department of Healthcare Services, both medical and claim services, as well as Community Services Division. And first up, we have Meredith Lee, who will be presenting today. Meredith Lee is the Health in All Policies lead from the California Department of Public Health Office of Health Equity. Meredith works in the Office of Health Equity, where the core of the work is changing the way government agencies work together, creating an environment where health and equity is regularly and systemically considered in policy decision-making. More specifically, she works to incorporate health and health equity into the state policy guidance documents and programs. So if you just give me one moment. And Meredith? Just making sure you're on the line. All right, so there may be some minor technical difficulties. However, we can move on to our next speaker. Dr. Karen Mark, are you on the line?
I am.
Wonderful, thank you. So I will take a moment to introduce Dr. Karen Mark, and thank you for being here. Dr. Karen Mark is our medical director for the Medi-Cal and Cal-AIM California Department of Healthcare Services. Dr. Mark will be speaking about Cal-AIM and how it will transform and strengthen Medi-Cal through identifying and managing the comprehensive needs of the whole person through addressing social drivers of health, improving quality outcomes, and reducing healthcare disparities and complexity within the system. Thank you, Dr. Mark. If you give me one moment, I will project your slides.
Thank you so much.
No problem.
Happy to be here. There we go. Thanks. So I wanted to just provide a quick update about CalAIM and some of the work that we're doing within Medi-Cal to really start addressing social determinants of health and make sure that we are addressing the needs of the whole person so that they can get the care that they need. If you want to go to the next slide. So I'm sure many of you are already familiar with CalAIM, but for those of you who are not, it stands for California Advancing and Innovating Medi-Cal. And it's really our long-term commitment to transform and strengthen Medi-Cal. It's a multi-year DHCS initiative to improve the quality of life and health outcomes for Medi-Cal beneficiaries. And the goal is ultimately a more equitable, coordinated, and patient-centered approach to maximizing health and people's overall life trajectory. The goals of so there's 3 goals of CalAIM. The first is to identify and manage comprehensive needs through whole person care approaches and social drivers of health. The second is to improve quality outcomes, reduce health disparities, and transform the delivery system through value-based initiatives, modernization, and payment reform. And then the third aim is to make Medi-Cal a more consistent and seamless system for enrollees to navigate by reducing complexity and increasing flexibility. So what we realized as we went through the process of developing CalAIM is that Medi-Cal has become more and more complex over years for many different reasons, as programs were added, et cetera. And it just becomes more and more difficult for people enrolled in Medi-Cal to navigate that complex system. So the goal is really to create more standardization throughout the state and make the system easier to navigate so that everyone can get the care that they need. Next slide. So CalAIM moves Medi-Cal towards a population health approach that prioritizes prevention and whole person care. It extends supports and services beyond hospitals and healthcare settings directly into the community, and it addresses social drivers of health, as well as physical, behavioral, developmental, dental, and long-term care needs, all the way from birth through the end of life. Next slide. And this slide sort of shows how CalAIM and population health work together for the future of Medi-Cal. And it's really based on having a foundation of preventative care for all of our beneficiaries, which of course is especially important for children who often are well. We want to make sure that they stay well. And then having patient-centered chronic disease management, and then whole person care for high-risk populations. This really is looking at addressing social determinants of health and leveraging several other things that I'll talk about in a minute. And we're doing this in part through data-driven improvements that address the whole person, through limiting racial disparities through community-centered collaboratives, and really improving transparency and accountability. Next slide. So population health management is a cohesive plan of action for addressing the needs of all enrollees. It's a whole system, person-centered strategy that focuses on wellness and prevention and includes assessments of health risks and health-related social needs, and then provides care management and care transitions across delivery systems and settings. So the Medi-Cal managed care plans will be required to implement a population health management strategy. In addition to that, we are implementing a population health management service, which will go live January 2023, that will integrate DHCS and other data streams that will allow us to perform analytics. So this includes things like risk stratification, identifying are beneficiaries that might need the most assistance in meeting their health goals. It'll provide health plans and provider networks integrated information about the patients that are assigned to them so that they can meet their needs. And then it will also provide beneficiaries a service to access data and health education and community services. Next slide. So another component of CalAIM is enhanced care management, or ECM. It's a new statewide benefit that went into effect January 1st this year, and it takes a whole person approach to care that addresses clinical and non-clinical needs of high-need Medi-Cal beneficiaries. And this takes a collaborative and interdisciplinary approach to providing intensive and comprehensive care management services to individuals. And it builds on the health homes and whole person care pilots, which were only available in certain areas of the state, and instead transitions those into a new statewide benefit. So it's present throughout. Next slide. The target populations for enhanced care management are listed here. There are folks who are high utilizers with frequent hospital or emergency department visits or admissions, individuals at risk for institutionalization with serious mental illness or other serious substance abuse disorders with co-occurring health conditions, folks at risk for institutionalization but are eligible for long-term care, nursing facility residents who might want to transition to the community, and children or youth with complex physical conditions, as well as those transitioning from incarceration and those experiencing or at risk of becoming homeless. Next slide. So community supports are another benefit that we're making available through CalAIM. And these used to be called in lieu of services, although that terminology is used as well sometimes. And this is, the managed care plans will integrate these community supports into their population health management strategy, often in combination with this enhanced care management benefit. The community supports focus on addressing combined medical and social determinants of health needs and avoiding higher levels of care. And they were originally called in lieu of services because they're provided instead of, as a substitute for, instead of more expensive hospital or nursing facility admissions, or like, for example, to prevent discharge delays or to prevent emergency department use. Next slide. So these are examples of community support. So a lot of services around housing, recuperative care, nursing facility transition to assisted living or home, personal care services in the home beyond what in-home supportive services currently provide, environmental home modifications, medically tailored meals, sobering centers, asthma remediation. So the idea is that some of these things, when not provided to patients, essentially lead to more hospitalizations, right? Like if someone is discharged from the hospital to the street and they can't take care of themselves, then they end up right back in the hospital. That's not serving anyone, least of all that person. But if instead we can provide them with some transitional, post-hospitalization housing and then transition them to permanent housing so they can take care of their health, that's obviously much better for them, and it also prevents future admissions. Next slide. So I wanted to just add by providing some examples because I think sometimes people see these, broad programs and it can be hard to understand how it really helps an individual. So, an example would be, for example, a 60-year-old gentleman who's been diagnosed with HIV for decades. He has well-controlled HIV, but was more recently diagnosed with diabetes and has also had kidney disease and heart disease related to his diabetes and his longstanding HIV. And perhaps is, living alone, doesn't have a lot of social support. He's been having a lot of emergency department visits and admissions for his poorly controlled diabetes and for the other diseases that result from the diabetes. And how this would work is that the Population Health Management Service will identify him as someone who is needing additional supports because he's having a lot of emergency department visits and admissions. His Medi-Cal managed care plan will then reach out to him and realize he needs something else to keep him healthy. And they can offer him enhanced care management, which he would qualify for as someone who's been having a lot of admissions. He can be given a care manager who can really do a full assessment of his needs. And they can realize that, you know, he needs assistance getting to his outpatient medical appointments. He needs assistance taking his medications. And they could also offer him medically tailored meals. Many people may realize it's, you know, if you're newly diagnosed with diabetes, there's a lot of rules about what you can and can't eat, and that's often very difficult for people to learn, especially if they're not great at cooking in the first place. So providing those medically tailored meals that both meet the needs of his diabetes as well as his heart disease and his renal disease would make a huge difference in helping keep him healthy and then keeping him out of the hospital. Another example could be, you know, a 28-year-old transgender woman who was newly diagnosed with HIV a year ago, who might have, you know, be experiencing homelessness and struggling to take her medications. You know, never actually has achieved viral suppression because she just doesn't have the support. You know, trying to make ends meet as being homeless in terms of taking her medications. So she also could be identified as someone who needs additional support and could be provided enhanced care management, some housing support to get her housing, and then ultimately the assistance getting to her appointments as well, and then the support that she needs so that she can take her medications regularly and achieve viral suppression and be healthy. So those are just a few quick examples. I'm happy to take questions if people have them.
And Dr. Mark, we do have a question for you in the chat, and I can read it off. It's from Brian Abascal, and he states, Dr. Mark, forgive me if I missed this, but is coverage of at-home nursing visits to administer long-acting injectables for HIV treatment and prevention being considered?
That's a great question. So I will have to look into that. I know there, I don't want to say offhand. I will double check and get back to you. I know the treatments themselves are covered, but whether the at-home nursing visits for injection, I'll check. Other questions?
There's another question in the chat from Antonia Dorsey, and it's an ongoing query that's been asked by many. Are we, as a state or as a group, going to improve data collection of trans populations?
That's a great question. It's something that we've been working on for quite some time. I know that we had run into, so the, you know, obviously in the healthcare system, there's been a lot of providers have made improvements in collecting appropriate data on people's gender identity. And within the Medi-Cal program itself, we have tried to do that as part of our enrollment process, you know, in a voluntary manner. We had, under the prior administration, you know, run into some issues with getting our forms approved by the federal government. And we're now, with obviously a newer administration, we're working on that process so that we can collect the information that we need to collect. Rachel's saying it's being worked on at CDPH too. Great. Other questions?
Hi, this is Dr. Phyllis Ritchie from PS Test. I'm in Palm Springs. We're free STI test and treat here. And I have a question about, and I'm not sure, I'm sorry I joined late, but I was wondering, and I'm not sure I'm asking at the right point, but is there a thought of perhaps providing some antibiotics such as bicillin to the free test and treat clinics. Bicillin now is $400 a dose for us, and it's expensive.
So is that question for the STD control branch?
Yes, I guess so. Sorry. I came in late. I apologize.
Yeah, I mean, I can just clarify. So I'm with the Medi-Cal program, and certainly we cover that for all of our beneficiaries. So
oh, sorry. Okay.
Okay,
Sorry about that.
Dr. Ritchie, what I might just say for you, and it might be helpful for anyone else too, is if you have things like that that would be really high impact and are important, which we're very interested in hearing. The last section of today, the last 10 to 15 minutes, we're going to give you 3 different ways today that you can provide those suggestions and information to us so that we can kind of take that back and make sure that as we continue to flesh out the blueprint for how we implement these strategies from today, that we keep those things in mind. So if you have ideas like that, we would love to hear them through those mechanisms, which we'll share around 1:45, how to share them.
Thanks. Sorry about that.
No problem. Thanks.
Any last questions for Dr. Karen Mark?
Hi, yes, I have a question. My name is Socorro, and I'm coming from, I'm from Santa Cruz County Health Department. So I was, and maybe I'm not sure if you'll be able to answer this question, is just how, for example, we provide case management through the Ryan White Part B program and how that might complement CalAIM.
Yeah, I can take a stab at that. So, obviously the Ryan White program does provide great case management. And I know often that's used as a wraparound service for things that someone's primary healthcare coverage doesn't cover. So, we are trying to, obviously, as I explained, expand care management within the Medi-Cal program. But for example, you might have someone who doesn't quite meet what would be required under enhanced care management. Maybe they haven't actually, maybe they're not homeless, maybe they haven't actually had, multiple emergency department visits, but they still need some assistance in case management. And that would be a great role for the Ryan White case management to assist with. Is that helpful?
Yeah.
Okay, thank you very much. We appreciate everyone. And of course, we invite everyone to ask questions in the chat, as well as towards the end of our presentation, allow for some open forum and feedback. And without further ado, I have Meredith Lee, who we will ask to be presenting next. Again, Meredith Lee is the Health and All Policies Lead with the California Department of Public Health, Office of Health Equity. We thank you for joining us, and I will now project your presentation.
Thanks, Lazara. And just to confirm, can everyone hear me okay? Oh, I just lost view of everybody else. Well, I wanted to start by, oh, thanks so much. I just wanted to start by thanking you all for having me here. And thank you. I want to acknowledge all the great work that this group is doing. As I was kind of scrolling through who all's here, seeing lots of familiar names and faces. And just wanted to thank you for being a leader in the field, your respective fields, but more broadly the field of health equity. And I'm going to talk today, actually taking a little bit of a step back and talking about some of the steps that we are taking both at the Health and Human Service Agency and down into CDPH and actually beyond to build equity infrastructure. And probably the longer title of this presentation would have been Building Equity Infrastructure, the Depth and Breadth Across Health and Human Services Agency. And again, my name is Meredith Lee. I use she, her pronouns. I'm actually the branch chief for our Advancing Community Equity branch, formerly the team lead for Health and All Policies, and really appreciate being here. In terms of just a little bit more of a preview of where I'm going to actually kind of take us through kind of a 60,000, 40,000, 30, 20, all the way down to the ground, talking about just the different equity infrastructure that we're trying to build. And with that, I'll actually go to the next slide, please. So I don't normally read slides, but this is actually, it's such a compelling slide that and the words are so strong that I do want to read it for everyone. So this is from our Cal Health and Human Services Agency, and this was released back in the fall as our North Star, and it says, we envision a healthy California for all, where every individual belongs to a strong and thriving community, where all our children can play and learn, and where we are confident that we have done all we can to pass to them a state that can lead into the future. Sorry, I actually make my screen a little bigger. Where older and disabled Californians can live with purpose and dignity, and where they are supported and valued. Where equity is not just a word or a concept, but the core value. Where we constantly pursue social and racial justice, not only lifting all boats, but especially those boats that need to be lifted more. Where healthcare is affordable, accessible, equitable, and high quality, so it drives towards improved health. Where we prioritize prevention and upstream factors that impact an individual's health and well-being. Where we are committed to tackling the economic inequalities that force many Californians to live on the street. Where necessities like housing and childcare are complemented by access to physical and behavioral health services. Where we see the whole person, and where programs and services address the social, cultural, linguistic needs of the individuals they serve. And where climate threats collide with forward-leaning public health practices that visibly turn the tide toward community resilience, and where we see our diversity as a strength, and where we embrace a joint responsibility to take care of one another. And I wanted to read that because I think it's just such powerful words coming from Health and Human Services, really talking about where we're going as an agency, as a state, and as a department. And next slide, please. And so one way we're starting to operationalize that work, that North Star in Health and Human Services Agency, is through what's called the JEDI, the Justice, Equity, Diversity, Inclusion Subcommittee. And this was announced back in the fall as well, at the same time we released our North Star. A couple of really exciting things that are happening is on the screen, you'll actually see two of our JEDI warriors. So Dr. Rohan Radhakrishna, our Deputy Director for the Office of Health Equity, and Marcela Ruiz, the Deputy Director for the Office of Equity at Department of Social Services. And the image below is the first in-person convening of the JEDI subcommittee. And the subcommittee is made up of equity officers or equity leads from all 12 of the HHS departments in the 5 offices. And one of the early things that they are actually doing is working to hire an chief equity officer at HHS level. And so I want to acknowledge that we know that having equity officers and having one person responsible for equity is not enough, but it is a critical first step to making sure that we can have equity considered throughout all of our policy programs and practices. And these equity officers are individuals positioned high within the organization who are being empowered and also being held accountable to elevate and advance equity on behalf of the department and the agency. Additionally, in the last budget, there were a number of some additional funding streams that were allocated, including $20 million to implement an agency-wide language access policy with resources to expand our ability to translate and adapt documents. Additionally, there was $4.2 million allocated to develop an equity dashboard across the major health and human services programs and to identify data gaps by race, ethnicity, sexual orientation, and gender identity. And then finally, a $5 million allocation to develop a training program for staff within Cal HHS departments and offices to support identifying and eliminating barriers to inclusive and just society. So again, that's kind of the 60,000. And I'm thinking about this as how do we embed equity and equity infrastructure throughout the entire system So this is our 60,000 foot view. If we go down next to our 40,000 foot view, here at CDPH, next slide, please. Here at CDPH, Dr. Aragon, our Director of Public Health, has named his 3 top priorities for the department. The first one being to become a learning organization by utilizing lean management and RBA, or results-based accountability, to become a healing organization, really centering equity and anti-racism, as well as trauma-informed and responsive practices. And finally, developing our people, so really focusing on professional development and core public health competencies. And he's talking about this all about CDPH transformation as that we're becoming the best at getting better, which I love because it's really bringing back that quality improvement or QI mentality to not only the work that we do, but to our organization as a whole. And so we're taking, next slide, please. We're taking, focusing specifically on becoming a healing organization. So back in 2017 now, the department adopted a racial and health equity initiative with a strategy and vision that says that states that California Department of Public Health has a vision for California in which race is no longer a predictor of one's health outcomes, and where all Californians can achieve their highest level of health and well-being. And we've been working on that now for the last 5 years, operationalizing it through a normalized, organized, and operationalized framework. Next slide, please. And as we go into and launch 2020 and really aligning with Dr. Aragon's priorities, we've on the right here, you'll see the kind of the updated visual that we have for our normalized, organized, operationalized, really centering at in the center of visual. How do we visualize the future that we want to see, and how do we and using these other steps is how we reach it. And then around the outside of the circle, thinking about trauma-informed and healing practices. And so, you know, I don't have time today to go into all the details of how we're going to do this. That's some of the next steps that we're working on right now, is developing a new plan about how we become this healing organization that centers equity and anti-racism. And so in the coming year or so, we'll have a lot more tools, resources, training so that we can offer to the department and also to our local health jurisdictions, with the goal of, again, really becoming, you know, that change that we really want to see on the ground. Going to the next slide, I'm going a little bit faster because I want to make sure we have some time for questions at the end. I probably packed this too full with too many slides. But going down, so we've talked about the 60,000, the 40,000. I put OHE, the Office of Health Equity, at the 30,000. If we go down to the 20,000 foot view, we know that having an Office of Health Equity, again, similar to having a Chief Equity Officer, is a good early step, and that we can't be everything to everyone. And so recently, this last year, we helped secure funding for 9 additional health equity liaisons to be embedded throughout CDPH at the center and office level. And again, this is going back to how do we actually do the breadth and the depth of embedding equity. And really excited to share that, in particular, first for the Center of Infectious Diseases here at CDPH, Sharon Eigenheim, I apologize, I think I just butchered her last name, is the equity liaison for Center of Infectious Disease. And you can see our other equity liaisons here. And the idea is these equity liaisons are positioned throughout the department where they can help to go deep within the department, supporting equity all the way down to the program level, and also being able to elevate where we're hearing barriers and challenges, and as well as successes, bringing those back to a department-wide level and being able to work and kind of elevate those up where there are challenges and needs. Additionally, it can work vice versa in terms of having to share information down into the programs. And so really excited to build this extra layer of equity infrastructure within the work that we have here at CDPH. And more, again, most of these folks, you'll notice there's a couple are still yet to be hired, but most of these folks are new to their roles. Some are not new to the department, but we just started convening the equity liaisons about 2 weeks ago. So a lot more to come from them as well. Next slide, please. All right, so moving down to the 10,000 foot view, and maybe this is 15,000, maybe not quite all the way down to 10, but wanted to share about how we're trying to build some more equity infrastructure at the local health jurisdiction level. And so through the California Equitable Recovery Initiative, also known as STI. You may also hear it referred to as the CDC Health Disparities Grant. We have awarded funding to 50 of the local health jurisdictions. The other 11 actually received direct allocations directly from the CDC. And so we wanted to ensure that all 61 had the opportunity to participate. And so we allocated a large portion of our funding to the local health jurisdictions with a number of asks. And one of the big ones, though, is to help establish an equity lead at the local health jurisdiction level. And we know that some departments or some local health jurisdictions have already done this, and they're really leading the way in terms of creating equity infrastructure. And we know that there are other counties who have struggled either for lack of resources or in financial resources or actual supportive resources. And so really trying to actually provide both of those. So this will provide both financial resources to hire somebody who can be the equity lead for the department, as well as additional resources to help support equity infrastructure. And whether that is additional trainings, whether that's supporting community engagement, whether, it's a wide range of things can fall into equity infrastructure. But really, again, trying to build up that capacity at the local level. A couple of other things, and I'll go into a little bit more detail in the next slides about STI, our STI program, is that two components that we're asking our LHJs to participate in is one, to conduct an organizational assessment, and we're calling it the baseline equity or baseline organizational assessment for equity infrastructure. And I have a couple slides on this in a second. And then a second one is actually to help contribute to our state health equity plan, which is a new plan that we're building at the state. And let's go ahead and go to the next slide, please. So just quickly, the baseline organizational assessment for equity infrastructure just went out to all LHJs earlier this month. We're actually anticipating responses back from the local health jurisdictions at the end of the month or early April, hopefully. And this is, we call it a baseline because there are a lot of other tools and resources out there to do organizational assessments. And so this is just a really high, we tried to make one that was accessible to all local health jurisdictions, regardless of where they are in their equity journey, to help provide that baseline data in terms of where they are. And the results of this assessment, we will share out at an aggregate level, but really it's to help us also inform where is their need. So what are the priority areas for technical assistance, and then really importantly, a lot of this information is going to roll into our state health equity plan. And then just to emphasize for LHJs on the call, our goal over the process of our STI grant is, while we'd love everybody to be a 6 on the spectrum, we know we're not all able to do that. And so really the goal is, how do we go from 1 step up? So if we're currently at a 2, how do we become a 3? If we're currently a 3, how do we become a 4? Next slide, please. I won't go into all the details of this. I can share out these slides and also the actual organizational assessment, but just to give you a snapshot of what's included in the org assessment. There's 4 different domains, and under each domain, there's a number of competencies. The domains range from workforce and capacity, collaborative partnerships, equity and organizational policies and practices, and then the 4th domain is around planning and shared decision making. And then I'm almost, I know I'm rushing here, and I can see there's a couple of chats coming in, but wanted to share just a little bit more about some coming opportunities to be engaged, and one of which is our state health equity plan. And so again, this is a new plan, and it's really, the goal is to have this be complementary and strategically integrated within California's Let's Get Healthy California, which is our state health improvement plan, our SHIP, and also to align with our Office of Health Equity Portrait of Promise, which is our strategic plan. And the idea is the plan will support coordination, alignment, learning across all of the work streams by defining a shared direction, as well as identifying priorities and menus of strategies. And we're going to be doing this all by using our results-based accountability framework to really try to align state and local performance metrics with shared population results in a common equity framework. Next slide. We are really early in the process for developing the state health equity plan. This is a very tentative timeline. Right now, we're kind of what I'd say in the initial phase of phase 1, where we're doing a lot of review of existing work plans, including including the CHAV, the CHAV and CHIPS from the local health jurisdictions, the community health assessments and the community health improvement plans, as well as a number of other plans that have been submitted throughout the pandemic, including there's a targeted investment plan. We had a work plan as part of SERI that was also submitted. And from that, we're going to be building kind of an initial framework and really then circulating that framework for feedback from a wide range of stakeholders. And then you can see the rest of the timeline. So that the goal is to have an initial framework within the next year, and then really to build out from there the plan over the following year. And again, more to come on this. There'll be a lot of opportunities to engage. And then shifting gears just really quickly, because I know I saw the theme around housing and homelessness and some of the other speakers, and just wanted to share that thanks to AB 1221, which was passed last year, CDPH is now part of the Interagency Housing on Homelessness, or the ICH, which is formerly the Homelessness Coordinating and Finance Council, or the HCFC. And so this is a huge opportunity for us as CDPH to really engage in with kind of a cross-sectoral and cross-organizational partnership to address housing and homelessness. If you go to the next slide, please. One of the areas that we are currently working on is reviewing the current ICH action plan, which was passed in March 2021. And they're actually already working on the next update. And I would just say that this plan is a really strong plan that really centers racial equity and encourage folks to take a look at it if you haven't already. But it didn't include public health in the last plan, as we weren't on the council. And I should also mention that in addition to adding CDPH to the council, it also added Secretary Galley, our HHS secretary, to co-chair the council with BCSH secretary. So it actually positions HHS at the very top and integrates CDPH into the body of the council. In the action plan, again, really strong, that we're listed here are the 5 key areas. And a couple of things that we are hoping to elevate and really bring to the next iteration of the action plan is re-emphasizing housing first. Also talking about the opportunity we have in terms of infectious disease prevention, doing a little bit more harm reduction, and then centering racial equity and centering the lived experience of people in the action plan. So there's going to be, if we go to the next slide, they're currently doing an internal process where they're meeting with council agencies and members to receive input, and then there will be a whole public process that begins May 31st at the May 31st ICH meeting. And so encourage folks to get involved there. I think it's an opportunity to really try to align resources, right? Recognizing that addressing homelessness and housing is sometimes seen as outside the lane of public health. And we recognize that housing is a necessary component of health, and without housing, without access to bathrooms and sanitation, et cetera, it's really hard for us to have any of the other goals that we want in terms of maintaining health. Anyway, so I encourage folks to get involved. And I believe, yep, next slide, please. That is my last slide.
Thank you so much, Meredith. Thank you, thank you. And I do want to apologize for providing the wrong title earlier. So thank you again. And we do welcome 1 or 2 questions, if there are any, for Meredith. And we encourage folks to put their questions in the chat as well.
Cynthia, I see your question. My email is here on the screen. Please feel free to shoot me an email and I can connect you to the right folks. And also if you can include your jurisdiction where you're coming from, and we can help connect you. I will say one area that we're hoping with, now that CDPH is part of ICH and we're trying to secure some additional resources, but it's also supporting LHJs make the connection to their continuums of care, their COCs. We know that in some jurisdictions, there's, the COCs and LHJs work very, very closely together, and then others where they don't know each other at all. And so that is an aspiration of ours is to help facilitate some of that matchmaking at the local level where it doesn't already exist. And thank you, Rachel.
Any last questions? And again, we welcome your questions in the chat. Otherwise, thank you so much, Meredith. We appreciate you being with us today. We're thankful to be able to have a partnership with you, and we will be moving on to our next speaker. So thank you. And our next key guest, or a guest speaker, excuse me, and yes, key guest as well, is Denise Galvez. Denise Galvez is the branch chief of the operations branch within the Community Services Division at the Department of Health Care Services. Denise is responsible for the administration of non-Medi-Cal prevention, wellness, and youth programs at the HCS. Denise's expertise is in the prevention of substance use disorders, addressing underserved populations. I welcome Denise, and I will be projecting your slides momentarily.
Okay, thank you very much. And hello, everyone. I am so grateful to have been invited to present at this very important town hall. I want to first say thank you to the CDPH team for developing this strategic plan, and more so that it is rooted in health equity and social determinants of health. I'm going to wait for her to. So I have a lot of slides today to power through, but we have a lot of programs to celebrate. Again, reminding people that these are all non-Medi-Cal programs and are largely funded by state dollars or federal grant dollars. And as we move through them, I will talk about how each is funded. So go ahead and go to the next slide, please. Thank you. So our learning objective today is simply to, in a very short time, celebrate some of the programs that have touch points with the strategic plan that was presented to you earlier, mostly around the objective number 4 with the mental health and substance use. Next slide, please. But before I start talking about the programs, I wanted to quickly touch on the data. Because when thinking about how to present and select the programs, because we have so many, I wanted to give some data on that shows the racial disparities that exist in overdose rates for opioids, and I'll have you take a look at that. And then next slide, please. As well as for cocaine-related overdose deaths, as you could see, Black African American and Native American Alaskan populations are disproportionately higher than other populations, and as they were with opioids. And then next slide, please. And that consistency continues with psychostimulant-related overdose rates with Native American and Black African American with the highest overdose rates per 100,000 population. So what are we doing to address the opioid crisis and the continuing disproportionality of substance use rates among communities of color? Is we have some major programs that I'm going to talk about today. So go ahead and go to the next slide, please. One of our largest and long-standing programs is our Medication Assisted Treatment Expansion Project, or you'll hear me refer to it as MAT or MAT. Next slide, please. So our California MAT Expansion Project aims to increase access to MAT services by reducing the unmet treatment need in California and reducing opioid overdose deaths. So this addresses rising overdose rates, and some of the work that I'm going to be talking about is some of the continuing augmentation to the MAT Expansion Project and all of our efforts to support new investments in our behavioral health infrastructure, low barrier access, harm reduction and prevention services, crisis services, and then accessibility to naloxone. Next slide, please. So before I get going on talking about the MAT project specifically, I wanted to take an opportunity to talk about through 2021 legislation, the Behavioral Health Continuum Infrastructure Program was established that awarded $2.2 billion to construct, acquire, and expand properties and invest in mobile crisis infrastructure related to behavioral health. And so in partnership with our contractor advocates for human potential, DHCS is releasing these funds through 6 grant rounds that will be coming up in this year, targeting various gaps in the state's behavioral health facility infrastructure. So through the BCHIP, you'll hear us call it BCHIP or BSIP funding efforts, it affords counties, tribal entities, nonprofits, and for-profit organizations the ability to expand their infrastructure around the entire continuum of care for individuals to meet growing demand for services and supports across their lifespan. And in addition to that funding, we also have over time, we have invested $491 million in grant funding from the Substance Abuse and Mental Health Services Administration, well, since 2017, in our state opioid response. That is the MAT expansion project. Next slide, please. So as you will see, the MAT expansion project, MAT is everywhere. It is across multiple domains, including justice settings, prevention settings, clinical settings. We have statewide programs, and then of course in an SUD treatment setting. So the California MAT expansion project ideally aims to increase MAT, as I mentioned before, reduce the unmet treatment need, and we continue to expand the project in many different ways that some of them I won't even get to today, but I have an exhaustive list later in this presentation. Next slide, please. So some of the objectives that were originally set out for the MAT expansion program were to develop additional MAT locations, provide MAT services to special and underserved populations, transform entry points and create effective referrals into treatment, develop processes to better manage high-risk transitions of care. So for example, in hospital reentry or in jail settings, engage prescribers to increase the provision of MAT, and of course, from the preventative lens, prevent opioid misuse and opioid use overdose deaths through naloxone distribution and other prevention programs. Next slide, please. So to date, we have implemented 30+ projects, have treated over 100,000 new patients receiving MAT services, have created more than 650 access points for MAT, have recorded 61,000 overdose reversals, have distributed more than 1.1 million naloxone units, and have served over 11,000 patients in stimulant treatment. Next slide, please. So again, here are some more numbers in some of the settings with 270 community access points, over 206 hospital emergency departments funded. We are also working with 31 county jail systems in 22 youth-specific treatment sites, 40 primary care sites, 10 mental health and SUD clinics, And then finally, 12 Indian health programs. And I will talk a little bit about some of those programs in detail. Next slide, please. So one of the projects is the naloxone distribution project, where DHCS is working to reduce opioid and prevent opioid-related deaths through the provision of free naloxone to qualified entities. And so since 2018, which was the inception of this program, the department has approved over 3,900 applications for naloxone, distributed over 1.1 million naloxone units, and reversed over 61,000 opioid overdoses. Next slide, please. So we wanted to, in alignment with the racial disparity and social determinants of health centered approach of the strategic plan that was presented earlier, we created a couple slides to give you all an idea of who is applying for the naloxone kits. So with law enforcement and criminal justice being the largest number of, thank you, of applications, followed by fire and EMT, EMS, first responders at 11%. And then in terms of the distribution, next slide, please. Harm reduction organizations and law enforcement are among the largest entities that are distributing the units. Next slide, please. The next program I'd like to talk about is the California Bridge, or you'll hear us call it CA Bridge. It is a program that we are in partnership with the Public Health Institute that works with hospital emergency departments to serve as the primary access point to provide access to MAT services and referral, and for and for ongoing care for mental health and substance use disorder services in the community. So as of February 2022, we have 206 hospitals that are participating in the program. And in spring of 2022, so probably the end, in the end of 2022, the CA Bridge program will utilize some federal funds that we have under the Home and Community-Based Services program here at DHCS, funded by the American Rescue Plan Act dollars. We have 40 million that will be distributed. We have 40 million that will be distributed probably through an RFA released in April, maybe even May. So we will keep this group apprised as that funding goes out. Next slide, please. So I wanted to give you some slides on the California Bridge impact to date, with funding going to 94,574 substance use navigator encounters, services to 76,000 patients identified with an opioid use disorder, and 32,000 encounters where MAT was prescribed or administered in, and this is in an emergency department setting. So one of the other settings that is priority, next slide please, is expanding MAT in county jails and prisons. And so this project is created to help counties increase access to MAT during incarceration and throughout involvement in justice system. This program offers technical assistance to 31 county-based teams that are developing or expanding their MAT services to individuals in county jails and through drug courts. The project is also offering technical assistance and training related to stimulant use disorder and co-occurring serious mental illness and substance use disorder. And so I'm happy to report on this project that more than 17,643 jail detainees have received MAT during their incarceration. And so next slide, please. I will just quickly go over this slide, but this is the original California Hub and Spoke system, that consists of a narcotic treatment program, which serves as our hubs in treating opioid use disorder. And they have spokes, which are office-based treatment settings that provide the ongoing care and maintenance and treatment. And so this map represents the widespread implementation of the California Hub and Spoke. Next slide, please. So the MAT Access Points is yet another program of dollars that have gone out to support MAT startup activities and MAT enhancement efforts in over 200 MAT Access Points throughout California. These MAT Access Points create low barrier MAT in syringe services programs, stimulant use prevention and treatment in communities of color. It is also supporting the Northern California Recovery Housing Project and opioid use and stimulant use prevention and recovery services in the LGBTQ+ community. Next slide, please. So I wanted to highlight how the MAT expansion is addressing communities of color and really creating change in those communities. And that is through training and resources to tribal communities through our Tribal MAT project. Thank you. MAT Access Points, funding for community-based organizations, and new funding available for stimulant treatment and piloting best practices. Next slide, please. So I'm going to go ahead, because in the interest of time, I have 3 minutes. I'm going to go ahead and say that we also have a Tribal MAT project. Next slide, please. That there are a breadth of MAT expansion projects that we are working on. Next slide, please. And here are some resources for you all to access in the slides. And then quickly, 2 more programs I want to talk about is our Assisted Outpatient Treatment Program, or Laura's Law. Next slide, please. And this program is named after Laura Wilcox. She was one of 3 people killed in Nevada County by an individual with a history of mental illness who was not engaged in treatment. And DHCS collects and allocates money for these services for assisted outpatient treatment programs. Next slide, please. Here are some data for the persons that we are serving through the AOT program. Next slide, please. And some of the successes of the AOT program. And then finally, with some upstream thinking in mind, we have our Elevate Youth California project. Next slide, please. That program is funded by the Proposition 64 Youth Education Prevention Early Intervention and Treatment account. It serves youth ages 12 to 26 in communities disproportionately affected by the war on drugs. And it is primarily youth social justice, peer-to-peer support and mentoring programs that prioritize the special populations such as LGBTQ youth, tribal youth, homeless youth, immigrant youth, and system-involved youth. So next slide, please. As of round 1 and 2, these are some of our program outcomes, and I will go ahead and go to the next slide, please. Serving over 11,000 youth, with about 10% of those youth being in the LGBTQ+ community. Next slide, please. And with a focus on meeting communities disproportionately affected by the war on drugs and communities of color. So we are largely serving Hispanic, Black, African, and other populations of color. And so with that, I will end and take any questions. Thank you.
Thank you so much, Denise. There are a few questions that are in the chat, and we have about nearly 2 minutes just to answer those questions. I know that you mentioned one in the past. We also have one from Laura Thomas regarding the naloxone distribution program. How are you planning to address the funding shortfall? There are multiple programs that are not receiving all of the naloxone that they're requesting. How can they help increase the funding for it, if at all, is one of the questions that we have.
So right now, the naloxone distribution program is primarily funded by the substance use, by SAMHSA dollars, by grant funding. And we do have sustainable funding in that area for now through our state opioid response grants. We do anticipate having an SOR third round that should be awarded to California shortly. And so that is right now our primary funding for naloxone distribution.
Thank you so much. There are a few other questions that I would love to point you to in the chat. Denise, thank you, thank you, thank you. We really appreciate you and your presentation and all the work that the division is doing. We appreciate all of our speakers today, and I want to turn it back to Shelly. Thank you.
Great, thank you so much to Lasada and to all of our speakers, all of our presenters today. We know this was a long time to be here and listen to people, and we really appreciate the many of you who have taken the time to listen to all of this today. We hope you're as enthusiastic as we are about this, the starting place that we think this is for California to continue to build a response to HIV, hepatitis C, and STIs. So before I tell you how you can get access to us by giving us your input before you end today, I did just want to say we've gotten many questions in the chat about copies of slides. And so we will be making copies of the slides and other materials presented today, including the recording, available on Facente Consulting's website and also on the CDPH Office of AIDS website. We'll provide links to that to anyone who is registered today, and you can of course share them as well. And so that you should just look for some information about that. It'll take us a few days to get it all organized and up, but then throughout this year, the pieces that Katie talked about today, we will plan to continue to update as things become available. We'll collect those resources in one place and make them available to all of you. So with that, I am going to share just a couple slides that are going to tell you how you can give us input today. So we have 3 ways that you can do that. The first is if you prefer to just use your words and tell someone in person with video or without, you can join one of our breakout rooms, and I'll tell you the instructions of how to do that momentarily because you will be in control of whether you go into a breakout room. So we'll have 3 rooms. In the first room, room number 1, you can join Lasada and share thoughts on racial equity, housing first, or health access for all strategies. In room 2, Sara Duran will be there and you can share thoughts on mental health and substance use, economic justice, or stigma-free strategies. And in room 3, Katie Burke will be there and you can share thoughts on the next steps, implications for health departments, what we'll be doing on our Facente Roadshow to many of your places in the next few months. And so I'll go to that in a moment. But we also have 2 other options. We have something called Mural, which if you haven't used it before, you don't have to have an account. You can enter as a visitor. We will put a link in the chat if it isn't already there. And then when you go to that link, it will open in your browser. You'll leave Zoom, but we would encourage you to mute yourself but leave Zoom open, because if you're having any technical assistance problems, we have someone there to help you, but they won't know unless you unmute yourself in the main room and say that you need assistance, and then they can help you. And finally, we'll leave the chat open. I will stay in the main room and be in the chat, watching the chat. And so you can utilize the chat function, put anything in there. I will try to respond, but as I said before, we will continue to capture everything that's in the chat and can follow up later.